Hi, thank you for coming onto this interview with me. If you would please introduce yourself for our
Well,
guests
first off, thanks
and
for having me,
viewers.
Lauren. I really appreciate the opportunity to address your folks. My name is I'm Dr. Mulvaney. I'm a physician, board certified in sports medicine and pain medicine. Anesthesia pain was my fellowship. Um, I have published about 10 peer-reviewed papers on the use of stellate ganglion block for the treatment of PTSD and the anxiety symptoms associated with PTSD. I was a Navy SEAL for 9 years, and then I was a physician in the Army for 22 years. And aside from my training, I spent all that time with special operations units, multiple worldwide deployments, combat deployments. And during that time, of course, you know, PTSD was out there, but it was never something that I felt like was mine to treat. That was always something that behavioral health did. The first time that they really started talking about it was after they'd known me for quite a while before they didn't bring it up. But it was,
Mhm.
I don't know, it actually serves me really well as I start taking care of people. And also really realizing that the if you look at the pie diagram of this country and PTSD, the veterans are just a little slice. It's such a huge, massive problem that lots of our citizens face. Then it keeps them from being, good, productive citizens leading happy lives. And but the nice thing about our work with veterans is we were able to, that's going to be able to be extrapolated to help a lot of other people as we move forward.
Yeah, I think I always say like in the military or veterans, we're everyone's guinea pigs because a lot of people are like, oh, but I want this shot or they're interested in it, and sometimes they get a little down when I'm always talking about the veteran perspective. But I mean, that's my perspective, but I also know that what happens to us and the proof that comes through us makes a huge impact on the rest of the medical community for
Yeah,
the rest of
exactly.
America and the world.
Yeah, exactly. And so that body of work, we've been publishing on this for 12 years now. I've personally treated over, I'm coming up to 2,400 folks treated with SGB for PTSD, or sometimes just they can't really get the diagnosis and they have generalized anxiety.
Mhm.
And that experience, that wealth of experience, and I spend about an hour with each new patient. That experience is very valuable for getting insight. And then when I was in the military, I was at one unit for a long period of time, and having that length of exposure, that longitudinal access to people, and seeing that what you're doing was actually working and changing their lives. That was another invaluable experience. A lot of physicians they don't get the feedback. They don't get to be in the gym with people or deploy with people that they've treated again and again, and to see that they're doing well. And then because of things like that, then we noticed you notice these trends coming. And honestly, we haven't done things the same 1 year. So, 1 year later, we're always doing something. We're adding, we're seeing things better. And one of the big things that really was looking at me for years that I just never really saw was, all right, all these active duty personnel who deploy to combat zones have PTSD, and then they come home and they are not their best versions of themselves when they have bad PTSD, that's for sure. Well,
Mhm.
who pays the price? So their spouses. So their spouses are really dealing with this, been described over and over again as Dr. Jekyll and Mr. Hyde, or they're walking on eggshells around him or her. And this is something where this problem has been looking at me for years, but I wasn't looking at it. And now I realize, holy cow, I ask, how's your spouse doing? What's going on with that? And when we ask these questions, I've been treating more and more spouses that are, because they're, though they feel guilty, like, hey, I wasn't in a combat zone, but I'm still dealing with this, very difficult situation. And I'm like, no, this is, you meet the criteria for PTSD. And they even
It's
say in like
secondary
the,
trauma.
yeah, and they say like in the DSM, now we're up to DSM-5, which is just the way the checklist for how you diagnose psychiatric disorders. And it even lists it in there that if you're exposed to the details of trauma in the course of your duties, and you can insert in the course of your life, that when you're exposed to that, it is another source of significant trauma. And if you don't
Thank you
corral
for
me in, I'm
bringing
gonna
that
be all
up.
over the place because I'll just
Yeah,
keep.
I know. Yeah, no, I just want to do caveat on that. No, one of my, I think I'm really lucky. My husband's extremely patient, and his father was a Vietnam vet, so he's used to being around other Army people, and then he married an Army person, and I think that one of the biggest things like I feel the worst about is how much he has to carry or how much he's had to dealing with me when I'm going in and out of that, just like spiraling in and out. But I don't know, veteran spouses put up with a lot, that's for sure. um, I guess next we'll go into really what are SGBs, stellate ganglion blocks, and how very specifically did you pinpoint that this was for PTSD versus just pain, or that this wasn't mental health, or that this is injury, or
Yeah, really. I mean, it's been in pretty widespread use. I mean, there was a textbook written on it by Daniel Moore in the 1950s, and it was in widespread use even back to the 1930s for various pain conditions. And it was done at the time, just with a needle unguided. They would feel down to a bony landmark and just drop the needle down. And they had good responses. And overall, it was a safe enough procedure. As we got better with medicine, they started using fluoroscopic guidance that was able to be at a measure of precision. And really now, the only way I learned how to do them under fluoroscopic guidance, and I would never do it that way again, because really ultrasound, now you can see soft tissue. So you can see the actual nerves, you can see the blood vessels, and you can avoid them. And by doing that, you can make it virtually a painless procedure. At its basics, the stellate ganglion block is a precision guided shot in the neck with a long-acting local anesthetic we use ropivacaine because it's the safest form of that particular drug. And all ropivacaine does, all that local anesthetic does, is stop nerves from conducting. That's it. So at its basics, that's what it is. Typically, we do this at the 6th cervical vertebrae level. So you have 7 cervical vertebrae, so kind of low at the level of, if you know what a lot of veterans know for a cricothyroidotomy, where their cricoid membrane is, that's usually C6, and that's usually where we most likely go in. And then we published a paper last summer. It was the first paper on 2-level blocks, which showed a strong trend towards improved outcomes when we added C4. And those were learned anecdotally from some people didn't do well at C6, but when we added C4, they did much better. So now we kind of do a 2-level block, or we offer a 2-level block to most people. When we do it, we go through, we spend a lot of time talking through what we're going to do with the patient. And then we describe it as, hey, we're going to clean off the skin with a skin cleaner that's called ChloraPrep. We're going to put some sterile ultrasound gel on. And then I'm just going to look, and I'm going to tell you everything I'm going to do every step of the way before I do it. And then I'm going to look, I'm going to identify all of the nerves and blood vessels that are in that area. And I let them know, hey, I'm actually a world expert at this. This is what I do. And then I tell them I'm take good care of you. I'm going to tell them the risks are extremely low. Risk of bleeding or infection is extremely low. And in skilled hands, the risk of anything like an injection into a blood vessel is also extremely low. So once we see everything, I'll ask permission to numb the skin on the side of their neck. And I tell them I put numbing medicine in my numbing medicine. So I actually, it's called buffering the lidocaine with sodium bicarbonate, which makes it so it doesn't sting. So it's virtually almost imperceptible that we numb the skin. And those are the last pain receptors we'll go by, because once you're inside the skin on the neck, you'll feel pressure and stretch, but there's no pain receptors. So once we are through there, I tell them I use a needle about the size of an acupuncture needle. So it's a 25 gauge 2-inch needle, which is a very thin, small needle. And it takes actually a lot of skill to guide that accurately, because it's a harder to see needle. So we precisely guide it down to where the cervical sympathetic chain is. So that's the fight or flight nervous system, the connection between the central autonomic network, the parts of the brain that make up your autonomic nervous system, and the nervous tissue in your body that makes up the rest of the autonomic nervous system. In this case, the sympathetic nervous system is what we're targeting, or the fight or flight nervous system. And it runs actually in a chain with some little bulbs called ganglion at time to time. And what we're going to do is just stop that. Through that chain, that cervical sympathetic chain is a two-way conversation between brain and body. People are under a misnomer that they think the brain's in charge. It is not in charge. It is just one of the voting members. And when it comes to your autonomic nervous system, and this is an important point, like you don't think about digesting your food. You don't think about breathing when you go to sleep. These are housekeeping survival functions that are just happening all the time without us thinking about it. We're cold, our skin contracts and we get goosebumps because we're now constricting blood flow to our skin. All these things are automatically happening. So then when I'm doing the injection, it's safe to talk. And I tell people that. I'm like, look, even people that are really nervous coming in, we spend a lot of time talking through them, a little tour of their neck. Hey, here's the anatomy. This is what we're looking at. Here's the different arteries and the anatomic landmarks, if they're interested. If they're not, I don't. But then we guide it down into place. And then I tell them it's going to take about 2 minutes. The slowness is part of the safety. And as I'm injecting, you might feel a little bit of pressure, but that should be about it. And then I tell them, if you feel anything weird, let me know. And I say, what's weird? Any funny taste in your mouth, any ringing in your ears, anything that you think is weird. And it's safe to talk. The needle doesn't move at all when you talk. It's not going through any muscles that move. It's comfortable. You won't feel it if you talk. And I go, and in fact, I'm going to ask you from time to time, hey, are you okay? Just checking in with you. If I'm not, just talking with them, I try to just talk with them about their life. Like if I know they like dogs, we'll talk about dogs. We just try to keep them, and I'll be, hey, you doing okay? Yeah. We do it. And then I tell them the needle comes out and then we'll wipe off the gel and I'll put a little Band-Aid on it. And I'll take the Band-Aid off before you leave because it's just a tiny little mark that's in the skin. And then I tell them, and then you'll lay flat for 5 minutes. After 5 minutes, we'll sit you up and we're going to score one eye versus the other. And we're looking for what's called a Horner syndrome. And what that is, it's a temporary effect where the eyelid will droop or the pupil will get smaller and the white part of the eye will get red. I publish these and put these in a paper because these are something you can see and you don't have to ask any questions. And so I train my medical assistants to score the blocks because I really can't say, nobody grades harder than me, but we actually give it a numerical grade by 2 people to ensure that we have some integrity that, hey, there was really a block done. And I did this because I saw a lot of physicians say, oh yeah, that's a good block. And I'm like, I don't see it. So I realized that sometimes you have a bias. Some people have a bias towards saying that they did great. Some people realize that they want their patients to do well and that they have to be honest about what they see. So we score the block. Almost always we have a very strong Horner's response. And this temporary response will last a couple of hours. I also tell them about 15% of people will get a hoarse voice or feel like there's something in the back of their throat. And that's because some of the local anesthetic will just spread over to the larynx, the voice box, which is right there. And if that happens, it won't interfere with their ability to breathe and it won't interfere with their ability to swallow, but it can feel weird. But that'll go away in a couple hours if it happens. That's not part of the Horner syndrome. That's just something that is known to happen with this. And the important thing about that is that possibility of having that hoarse voice is why we can't do the left and the right on the same day. And people that do that, unfortunately, don't understand their anatomy and they actually scare the crap out of me. And whenever I find out they're doing it, I try to let them know that that's unsafe. But some of them continue to do it, and I don't know why. And here's the reason why. When you look down, for those of you that don't look down the throat or at vocal cords, they look kind of like this. And when you phonate, when you talk, they go in and out, and this tube is going down to your lungs. So the vocal cords make sound as the air is passing out. Well, when a vocal cord becomes paralyzed, and this is the design flaw, which I'm going to have a conversation after. If there's anything up there when I die, I'll have this conversation. I'm like, hey, when the vocal cord is paralyzed, it should be paralyzed in the open position, but it's not what it does. When it becomes paralyzed, it paralyzes in the closed position. And then if you did it on both sides, they could both be closed. That would be a horrible airway emergency. At best, it would be immensely anxiety provoking. And at worst, it could be lethal. I mean, this is very important not to do because the last thing I want is someone to be harmed by something that I've seen help so many. And even though the person that did it would have been absolutely ignorant of anatomy, absolutely in medical malpractice. The fact is, it'll say this stellate ganglion block killed somebody. And
Yep.
I can't have this, I don't want the well muddied like that, and something that I've
Mhm.
seen help so many people.
100%.
So after we do C6, then we do C4 in the same fashion. I do it with a lot less anesthetic. These days, I'm only using about 2 mLs of anesthetic at the higher one. I'm using about 7 or so at the lower one at C6. So after 5 minutes, we sit up, we score the block, then they lay back down for 20 minutes, and we let that kind of reset happen. And we'll talk about what's happening in a sec. And then we have them sit up in a chair for 5 minutes. They're doing okay. That's it. And then we follow up. We follow up at 1 week. We follow up at 1 month. I'd love to follow up longer from folks. And everyone is so ready to give you follow up when they're leaving. And then when they're doing good, they just kind of forget about it. It's kind of like when the dentist tells me I need to floss twice a day, maybe.
No, I experience that a lot with people that I talk to that like are like, "Oh yeah, I want to talk about the SGB," and then they get it, and then afterwards they just like coast back into normal life, or they just when you're not in pain, I guess it's not the one thing you want to talk about all the time. So
Yeah, absolutely. And the one thing that's going on when we do this, like what is happening when we do a stellate ganglion block, and that's the, and let me put a disclaimer out there. This is a well-developed hypothesis, but it's a hypothesis. What we see is that the neural tissue of the central autonomic network, some people have heard of like the different parts that make that up, like the amygdala or the insular cortex or the prefrontal gyrus. There's all these little elements of the central autonomic network that controls the autonomic response in the body. And these elements talk to, communicate with in a two-way, afferent and efferent, a two-way conversation to the neural tissue in the rest of the body. In the gut, it's predominantly through the parasympathetic or the the kind of the feed and breathe nervous system. And going out to all of the rest of the body is these elements of the fight or flight nervous system or the sympathetic nervous system. And we've all experienced like the sympathetic nervous system. If you've ever driven at night in the rain, it's heavy rain, and somebody slams on the brakes in front of you and you realize I am hydroplaning, I might hit them. It's not, there's no like the adrenal hormone, adrenaline's released from the adrenal glands over the kidneys. No, it's, you see that you're about to have grievous bodily harm. Your amygdala is always taking in all sensory input, and it says danger, and it flashes, and in the speed of neural conduct, whoosh, you are 100% ready to go. You have shunted blood to your gut. You have put blood out to your muscles to get ready for fight or flight. Your eyes will dilate. They will get bigger to see in the corners where the danger is coming from. It is a series of complex responses that is a survival adaptation. And that's what this is happening. It's a survival adaptation. What happens in PTSD is, in most cases, people with PTSD or post-traumatic stress injury is how I prefer to call it, but it's not as popular a term. But what happens is the neural tissue in the brain, the central autonomic network, is amping the neural tissue in the body, and the neural tissue in the body is in turn amping the brain. And we've seen, there's another example of this where if you've ever just made a fist long enough, your face will even change. You make that fist and you will start, over time, you'll feel more tense. Now, I told my hand to make a fist. The fist is communicating on its own, back channel through the autonomic nervous system saying, I don't know what's going on, but get ready. And I told my fist what to do. So the problem is that this covers why a lot of people think they have this sense that I should just be able to pick myself up by my bootstraps. There is not cognition. There's no cognitive input to this system that can turn this off. And they feel tremendous guilt. People with post-traumatic stress injury feel tremendous guilt because they can't just get over it. Why am I dealing with this? And a lot of them don't know other people are dealing with this in the same situation. They feel very cut off and alone because they don't want to be around other people. So this is something where I always address the guilt associated with having post-traumatic stress injury. And the way that I describe it is I say, okay, when I look at your elevated PCL-5 score, the questionnaire score, and I look at that and it's a very high score, it's the same as when I look at an x-ray of someone with a broken femur. They've got this broken leg, it's clearly broken. And I go, the difference is the person with the broken leg doesn't feel guilty because they can't get over it. And they don't feel guilty because they can't run. Of course they can't get, and they're not going to, they know that if you hand them some pills or some lotion, that's not going to fix their broken leg. It's got to be fixed right. And if it's not fixed right, they don't, why am I supposed to feel guilty about this broken leg? But people with post-traumatic stress injury, which is the same injury, this thing got looped. You had no thought process, no cognitive thought process. Despite our flight nervous system got looped. And now it's stuck. And you can't like just bootstrap out of it. You can't think your way out of it. It is a system, a survival mechanism that got stuck. And
I tried so much. I tried so hard to get
people do. It's heartbreaking.
Out of it. I thought that I had control over this, but I didn't have control of keeping it on. So how the heck could I have control of turning it off?
No, it's that's the crux of what I want to get at, because really it's like a computer with a blue screen of death. It's locked up. You can't code your way. Bill Gates can't code his way through it. What do you have to do? You reach down, unplug it, plug it back in. And when you do that, it comes back on in its factory settings. Well, these people feel this guilt because they don't know how to unplug it. They don't know how to reset this system, and they think they can just pressure their way through it. And I actually spend a good bit of time trying to get them to this awareness that this is an injury and that you feel a tremendous amount of guilt because you can't just get over it, but you've never been treated properly for it. And the thing is, I'm not down on behavioral health at all, but even behavioral health has its limitations. And I see so many people with max scores really suffering that have had all kinds of pharmacological treatment on 4 drugs and been through inpatient, outpatient treatments, and they're still not better. It's not because they're not good, caring healthcare providers. It's because you're stuck. So first we unstick you. And then I go over like, hey, people with a broken leg don't feel guilty because they can't run, but they feel tremendous guilt because they're, let's just say, not the best versions of themselves when they have PTSD. And the big thing is there's always tremendous guilt, especially around flash anger against kids, flash anger against spouses, flash anger against people that really didn't deserve it. And they feel horrible about it. And I see people involved in legal problems because of it. And they feel they've been boarded out of the military because of it, which is, quite horrible. Like they have this impulse control problem associated with a post-traumatic stress injury, and it was never treated properly. If I can get them to look at it from my optic, from my point of view, that this is an injury, then that guilt is ameliorated. And that if we can reduce that guilt, I'm 3/4 of the way to making them better. That guilt weighs on people and they feel like, why can't I get over it? Why am I such an ass? Why did I do that? Why am I drinking every night? You're drinking every night because you're treating your symptoms. You're drinking every night because you're trying to make that horrible feeling go away. You're self-medicating. And whether you self-medicate with benzodiazepines that were prescribed by a doctor, whether or not you do it with marijuana, whether you do it with alcohol, you're self-medicating a symptom. My goal is always to fix the condition, always get you back to fixing the condition. And then what do you have to do? Then you still have hard work to do. You still have to do the self-care. You still have to do the other keys to living a good life, but we can help get you over this now insurmountable obstacle and get you back to where you feel hope and feel in control. And if we give you that optic that, hey, this is an injury, that guilt is inappropriate, we're going to reset the system. And then we follow it up with this kind of counseling, informal counseling that we just go through, trying to give them awareness. And then when we do the SGB, and I don't like telling people what they're supposed to feel with an SGB, but it's good. And it's not, it doesn't take forever. But the results are pretty dramatic. And when you give them, when you do that, what they feel is hope. And I have to tell you, I have tons of people just weeping in my office after having that done because they were in such a dark space. And the other thing I tell people is, especially people with very elevated PTSD scores, I'm just very frank. I'm like, look, if your score is over 65, getting into the 70s and 80s, the maximum score is 80. If you have a very high score, of course you're thinking of killing yourself. So there it is. And it's one of these things where I just tell them, I go, look, you're a veteran or a police officer, you're a problem solver. You're given all kinds of problems. And you're like, okay, I can't live this way. So I'll take their drugs and I'll go to their counseling, or go to their inpatient counseling. I still feel this way. I have to get off the X. How do I get off the X? And they don't really want to do that, but most of them have seriously contemplated it, if not attempted it. This is something where I just want to get the word out, like, don't do it. You haven't been treated properly. Let's get you reset. And it is an emotional event for them to be pulled back from the brink. Now, I will tell you, as a physician, earlier on, when I was figured out that this was working so well, my guys would come in, and of course they knew my background, they knew, and I was in the same units, doing the same. I was strong enough to hear those stories. I did. The rest of my life was pretty stable. I had good, healthcare and exercise, and able to bleed off the stressors of the day. But in a year, I wasn't okay. You can't hear those stories. The stories that got you to the place that you're in, you have to treat it like toxic waste. It's toxic waste, and it's just like. And I see guys all the time where they're like, "Hey, you want some of my toxic waste? Want to sip of some of my toxic waste?" And I think a very unproductive thing is for veterans to get together and talk about horrible things, because how do you study for a test? You go over it again and again, and you lay down that memory. Why do you want to lay down that memory? Those defense mechanisms. So like you look like the model of the World War II vet going to the VFW, and he's sitting down, and what do? They just be around people in the fold. They didn't talk about it, and they had a couple beers. Maybe too many. Maybe that wasn't really the best way of dealing with it. But I don't think that talking about the stories are toxic. And I've heard stories I can't unhear. And so now what I do is I really focus at, okay, this is an injury. And I tell them, when I'm looking at that x-ray of the broken leg, did they slip and fall in front of Walmart? Did they fall 30 feet out of a helicopter? It doesn't matter that much to me as far as fixing that leg. So how it got there. Yeah, go ahead.
I think this is like something that really resonated with me about you. Because the first time that I ever heard about you was that 60-minute interview. Somebody had sent me the link for it, and I actually just read it, and I was crying by the time I was done. And I was like, the way they worded this, like, this makes medical sense to me. I was a medic. I'm like, this makes sense. Like, fight or flight, all I've been asking is for people to turn this stuff off. Like, I have a problem. I don't have a mental problem. My brain isn't jacked up. There's something wrong in my body that is happening that causes me to feel this way and to think this way. And I had a lot of physical symptoms too. And it just like, it rocked everything. But changing and seeing that perspective of like, this is an injury, because I couldn't go to therapy anymore. I was so sick of talking or giving a bunch of trauma collectors. And that's what I feel like. It felt like going to all my therapist appointments. Like, they're just trying to collect my trauma. And I'm like, my trauma is something that or my story is something that I get to carry in my brain for the rest of my life. I don't need to keep saying, I remember every moment. I don't have to re-say it to you. There was a guy in there that said that about like, oh, my cat, hi. There was a guy in the 60-minute interview that talked, he was in his like red polo shirt. And he was like, I already know what happened. I don't need to talk about the story. I remember it. I see it every night. Like, I just need you to get my body to stop looping on it. And when I got that shot, the doctors had to hold me down, because I felt it so viscerally, so immediately. And I was like, oh my God, you guys did it. Like, and then the waterworks came. But it was an injury. There was something physically wrong with me, and my brain was still there. Like, I walked away and I was like, I'm still me. Like, I can still get upset. I can still have emotions. I'm just me without my nervous system on fire.
Yeah. Can I tell you something that's actually, it sounds kind of messed up. But even those traumatic memories, even that bad stuff, it's still, like it or not, it's part of the fabric of who you are. Yeah. And what we want is those bad memories to stay on the shelf, to not come down and wreak havoc in our lives. We can't really make them go away. There's no eternal sunshine of the spotless mind, but we want those memories to behave and not mess up with our day to day. And here's the kind of thing that's a little bit messed up is even those traumatic things, some of them, not all of them, but they leave the people in a place where they feel like they wouldn't want to get rid of those memories, that those memories are
Yeah.
now part of them. And
I don't want to get rid of
you know,
the memories that were most traumatic to me because there's people I love very much that I miss now. Like I just had a combat anniversary on Friday. I'm sorry, this just makes me really emotional, just in general. But like I spent the day crying. I cried. My husband was off work. He took care of the baby while I was just in and out of emotions. And I was like, I need to feel all this. Like this is an anniversary. I'm gonna remember this every time, and then I'm gonna grieve for the people I lost because I love them, and I don't ever want to forget them,
here's the
even
good
though the
news, bad news
situations were
story is
bad.
good news, bad news story is I take care of a lot of Vietnam veterans, and my clinic is always fills up around Tet, and we when it gets bad, we just treat it and put it down. A lot of those guys are fall into the one and done category though.
Mhm.
So some of them just have never been treated, and then when we treat them, they're here just 50 years ago, and they're like, I'm finally home. So it's actually pretty crazy that
Yeah.
that loop doesn't necessarily break with time. And so, and I have still have contact with a lot of these long-term guys that have had stuff. Even the very first patient, the patient that got me going with this, he had crashed his car, and I was evaluating him after crashing his car, and I'm like, what the heck happened to you? And we were in the rear, and he's like, I fell asleep while driving. I'm like, it's the afternoon, why'd you fall asleep while driving? He's like, I'm taking Seroquel, an antipsychotic. I'm like, why are you taking Seroquel? He goes, to control my nightmares for my PTSD. And although I don't like going into stories in general, his trauma dated back to Desert Storm. He was involved in the ground combat, and it had a lot of the elements that are like kind of like classic PTSD. It was very intense ground combat. They were assaulted through a bunker complex. A door had actually blown up backwards on him and knocked him briefly unconscious. They finished assaulting through the targets. And when it was all done, and this is the thing that folks don't really talk about too much, but they did desecrate some of the bodies. And so a shameful act, that moral injury, and we don't really talk about moral injury. When the blood was up, and this is not something to look back and judge on, this is something that it happened, and I felt intense shame about. And his symptoms didn't go abated. And he would describe, a lot of people don't even know what a flashback is. A flashback isn't a memory. A flashback is a current happening. It's an entire packet of memory that comes back in all of its intensity. And he would describe
Mhm.
driving his car and then having a funny smell of cordite, of ammunition and spent cordite. And then he'd actually feel a blast wave hit him right before the blast wave that knocked him unconscious. So there he had an element of TBI, an element of killing in close quarters combat, an intense combat, and then shameful acts. And people they don't really talk about the latter of them, but it
Mhm.
happens, and it can make a deadly witch's brew of post-traumatic stress injury that will not go away. So for those folks, we need to reset them. And then here it is, our country put them into this situation that a lot of times gets very sideways, and and it's not really for people that have never been in those situations to hold judgment on them, at least not out of pocket, out of hand. I think you really have to
Absolutely.
look at this. It's very tough. I'm not saying never, and I'm saying that there are things that truly are crimes, but sometimes it's just so hard to say. But they come home broken, absolutely broken, and they won't
I
get
couldn't
fixed.
I couldn't drive. I couldn't even cross a street. But
Yeah.
at the point where I felt my experience, and I expected to feel a flashback like how I saw in movies. Like I thought like it was gonna be like that. And I think the only thing that's come close to explaining or getting close to the way I feel whenever I had those experiences was like something from Handmaid's Tale in like the last 2 episodes in it. It was like when she like gets off this airplane or off the boat and she walks in and she's like that moment of like breath. Just It's like you're feeling this and no one else is feeling it, or you're taken away into some other place. It just was not the way I expected a flashback to feel like. So I thought that what I was experiencing wasn't a flashbacks at all. Because I expected to see the same exact thing as what I saw elsewhere. And I don't know. It was different than I had thought about for the 14 years I was in the military.
Yeah, it's a tough one to describe or even get through to people. And once we do treat people, though, about 1/3 of the people I treat are kind of fall into this one and done category. Or and through this all, I really want to mention Jim Lynch. He's currently not really deployed. He's currently supporting the Olympic Games in Tokyo. He's the doctor to USA Swimming. But about 1/3 of the people I treat just need some leg room to get away from the problem. And when they do, we start an upward spiral where they start to sleep better. They start to repair relationships around them. It doesn't take a lot of energy for them to be in crowds now, and their resilience grows. It grows to the point where the things that might have triggered them won't trigger them again. Some people will get triggered again, maybe months, maybe years. If we were all going to have bad days, but when it really starts to backslide, that I tell them, and this is a big point, do not feel guilty if you need to get another treatment, because you had nothing to do with the first time you looped, and you don't have anything to do with this time when you looped. So you just weren't resilient enough to take those hits that you're around. And some people, they get a block and then they happen to find themselves in very stressful situations. Or some people get a block when they have undergoing legal issues, sometimes from their behavior from PTSD, or they're going into a hard divorce, many times precipitated by their post-traumatic stress injury. So when they're going back into a very stressful situation, I tell them it's kind of like if I'm the world's greatest thumb doctor and I fix your thumb, but every night you go home and hit your thumb with a hammer. It's hard to keep that thumb fixed. So there's that element, but even sometimes you won't know what happens, you're doing well, and then you just start to backslide. If you need to get retreated, it is not a failure. You shouldn't have any guilt about it, like you shouldn't have any guilt about the first time. If that happens, then we just don't let it get bad. Don't let it get all the way down the drain. Let's just treat it and get you back. And then this is where we have this, look at, did you have a right side before? Should we do a right side again? Should we add the left side? We published a paper last winter, and basically we showed like 1 in 20 people really only respond on the left-hand side. Why is this? I'm not sure, but I know that we're all wired differently. Some people respond. What we saw in the course of figuring that number out was that really most people, even if they respond on the right side, some people will respond better on the left side. There's all iterations of that. And what we saw is in most people, there's input from the left and the right side. And then due to neuroplasticity, just because something worked before, it doesn't necessarily mean that same combination will work again, because your brain is changing. As we reduce your stress, as you start getting better, the size of those plumbing, whether it's a 2-inch pipe or a 1/4-inch pipe or a 1/2-inch pipe, the size of the conduit that moves between the central autonomic network, or how your body responds, neuroplasticity says these things are changing. And we know this from functional imaging of the brain, where we see the brains of people with post-traumatic stress injury actually look weird. The amygdala on the left-hand side gets bigger. Why is that? So there's so many questions. I approach it in a kind of workman-like, practical fashion, which is, how do we help this person in front of me? And sometimes we treat the right side on one day with a 2-level block and the left side on the other with a 2-level block. That sometimes works. Some people just need a right-sided block. Sometimes we figure out, and then we have all little iterations of this. Some people respond great to a 2-level block. I have 3 patients that respond much better to a single-level C6 block, and I can't explain it, but they had enough experience to know, no, that one didn't work for me. And so that's the thing, is keeping track
That's
of.
how I felt about because I think I've had one upper. It didn't do anything different than what this one did, because I get so much pain relief. I don't know if or what it is about that, but and then I see all the comments from other people and how all these different bodies respond differently. And that's just interesting. It's interesting to
Yeah.
see.
it's interesting, but overwhelmingly, we have the lion's share we're able to get our hands around and treat them well. And the one thing I want to bring up is like I've I've done most of the studies on or been a part of, or in many of them lead author on, the actual studies that look at this and say what's going on. The only thing we've ever injected is 0.5% ropivacaine. That's it.
Okay.
So I see all kinds of people now, and I'm bringing this up because it's not because they're necessarily wrong, but they're putting all kinds of other adulterants into the 0.5% ropivacaine, and they're saying that that's somehow adding something. And all these other things that they are putting into the block, none of them have been studied. And so everyone's looking for their own little take or their angle. Or I see people, yeah, well, I do it this way. Okay, based on what? What study have you done that you've put out for peer review in medical literature that says, and so I see people getting kind of cavalier about this, and they're just like doing their own thing. And even things like pulsed radiofrequency ablation, it's called pulsed RF or just pulsed RF. When they do that, they're actually doing a regular block and then doing that. And then they're saying, oh, we see great results with it. I'm like, okay, where's the study? I'm fine with people, if they really are seeing something. My point is that they need to back it up in the peer-reviewed medical literature and let us see. Because if there's a better way to do it, I want to do it. I'm definitely not saying my way is the best way, but I'm saying that, hey, if you want to do it a different way, it's a lot of hard work. And you either do the work for the betterment of the medical community and all the thousands and millions of patients that you can potentially treat, or you just do your own little weird thing and you never put it out there to be evaluated.
Mm-hmm.
So that's, and who knows whether or not it's good, it's bad, we don't know.
Right. No, it's good to know what you put in that, because people are always asking, because I've gone to places and they put steroid in something.
Why? Based
Holy
on
crap,
what?
I thought my heart was gonna explode. I don't know. It didn't feel good, I'll tell you that. I did not like it. I'm like, please just numbing. That's all I
Well,
want.
the thing is, they do these things, and your heart was probably going to explode because they probably put some epinephrine into it, and that can. Some people
Oh
are
God,
very
I hate
sensitive to
epi.
that.
I am.
But I'm not against this. I'm not against people finding a better way. But I'm like, hey, if you're not going to do the research, then don't do something. Why do something weird? And there's some stuff that's
Because
been
you could
done in
hurt
classically in
somebody.
anesthesia where they will add clonidine to a block, a very standard technique, and it makes the block last longer. Well, who's to say that this is a case where that block needs to last longer? I think that as long as you get a good dense block and that block happens over several hours, I think that that's doing what it's supposed to do. And I haven't had anyone show anything or publish anything otherwise. So I don't know. I'm disciplined in my approach, and because I want to help people and I don't want to hurt people and I don't want to just do something. All of the
How
stuff
do
we
you
did, as
feel
soon as we
about
found it
like
out, we
giving
published.
giving sedation to people when they get the block? Personally, now that I've had it, I love that on my first time I didn't have sedation, because I feel like I felt what was happening in my body, and I like being kind of like in control. I don't like being loopy or out of it, which is funny because I think everyone just assumes like I want to be high all the time because I'm of like all the things we promote, and I'm like, that's not it. I don't like feeling high. So in that way, especially not with meds that are in my body. So what do you think about that? Like, what is your opinion on
I
sedation
think
versus not sedation?
I think that if you spend time and talk with people and are calm and reassuring in a calm and reassuring setting, I have done all of my 2,400 SGVs without sedation. I've had 2 people that needed to use Valium by mouth before they came to the office, and that's it. Because here's the deal: at the end of the day, it's not painful. It's a less than 1 out of 10 for pain. It's a little weird. It's your neck, but if you have somebody that really knows what you're doing, and you shouldn't be seeing someone if you don't trust them, but it's not painful. And then you get to see what happens, because what I look for after the block, after the Horners, and once they're, and I don't like to, I don't like even like talking about this stuff, but I look for certain things to happen that indicate that we didn't just, the eye is just an external gauge. I'm not looking to treat the eye. I'm looking to treat the mind and the body. And I'm looking for things that tell me that the mind and the body have reset. And I don't like leading people on what those things are, but I also can't evaluate them if they've been sedated. So how do I know if I really got, my real goal is making them feel better? How do I know if I did that? Additional fees to people for sedation, and I don't feel that the risk. I don't feel the risk is worth it, because I've done more than anyone for this indication. I'll put my numbers up against anyone that's ever done this. If you do it right and you're calm and you're taking care of people and you have the skill to do it, it's virtually painless. And and then some people can be really anxious about it. I got it, and they overcome, and then they get this wave, and it's very cathartic after we're done.
Yes.
And it's
I
and
think
it's
that's
huge.
the right word. It's extremely cathartic to feel the relief, because if you already feel the relief from sedation, like Valium or whatever it is that they're going to give you, um, like it's deadened. The relief you're going to feel is deadened. So then you go in tomorrow, you wake up and yeah, you may not feel that sedation anymore, but like I don't know, it was like getting the shot, like you feel all the relief in all these places. And I feel like it's so important to know what is being relieved, and knowing that it's not all in your brain, and that this was a legitimate injury and you need to feel that this was real relief, and you don't get that with sedation.
It is a huge therapeutic window that you don't get otherwise, and I always
Yes.
take advantage of that therapeutic window. Because how did you feel after your blocks, Lauren? Did you feel a little high? Feel a little relaxed, calm?
I felt amazing. I felt like I
Some
was
people feel
18
like they
years
had a
old
few
again.
drinks.
Yeah, yeah, yeah. It was euphoric.
Yeah,
And then I got to hold my baby,
yeah.
and like
And so what I
it was
tell people,
amazing.
and then what I do is I let people know, especially with veterans, it's easy because I say, hey, have you worn a heavy rucksack? Yes. How do you feel right when you take that rucksack off? I feel like I'm floating. I feel awesome. Okay, what's in the rucksack that makes you feel awesome? There's nothing in the rucksack that makes you feel awesome. You're feeling the absence of the rucksack. And there's nothing in 0.5% ropivacaine that makes you feel calm, relaxed, high, like you had a few drinks. It doesn't do it. Nobody steals it off the paramedic trucks. Nobody steals it because it just makes a numb spot. But when you use it to turn off the fight or flight nervous system and reset it, and you still have one on the other side, so you're still okay. But when you use it to reset it, what you're feeling is the absence of anxiety. And that's the
Mhm.
rucksack that comes off. And that's where those feelings come from. And to be there and witness that is like the best part of my day. And if they were sedated,
Imagine.
they would miss that. They
Yes.
would miss that therapeutic window of what just happened to me. And it's
Yes.
amazing.
Because then I feel like also now, 2 years post my first one that I got at the VA in Long Beach, I like knowing what relief happened let me know that those things were associated with this injury. So I can separate now a mental what I'm feeling as a mental symptom and a physical symptom, and I recognize which one's which and when they're turning on. And like if I feel like a loop is going to happen, or like I have control, but I couldn't have had that control if I didn't identify what the problem was first. And I feel like you get to identify it without the sedation
Yeah.
in
And I
some
actually went out,
therapeutic way.
I actually flew out to that exact hospital at Long Beach, and I taught a bunch of their anesthesiologists. I gave them my whole protocol. Hey, here it is. This is how I do it. And went through it, brought them out to a friend of mine who is in LA that does these with a high level of skill. Had them watch what was going on with that, and then I had them come back to the VA and had them do them. But Yeah, we did some training with those guys.
Yeah. I think the people that you trained gave me my shot, and
Oh,
they were
awesome.
the awesome people. When I walked in, I asked, "Hey, I'm going crazy, but I don't want anyone else to raise my kid because I feel like I'm going to lose my mind. Can I please get one of these shots?" And my doctor was like, "No, we don't know where those are." I was like, funny because there was just a TV show about it, about this specific VA. And it took me 2 weeks. I found them. I walked in and they were like, "Totally, we'll get you on the schedule." And I was like, and
That's awesome.
I knew from what you guys, what you and all the other people in that 60-minute interview, like the little clips or the people, and then looking at your videos and the little bit that was out there that I could find, I was like, this is it. This is going to take care of it. This is exactly what I've been asking the VA to do. I was like, turn my fight or flight response off because I can't turn it off myself.
Well, I'm so glad that you had a really fantastic response to it.
Or if you could say anything to people that are being cavalier as providers out there and doing these, thinking that they're doing the right thing, if there's anything you could say for providers or for patients to that you think if they go and approach other doctors, or like what you think that they should know or say, or just to mitigate risk for people. Like, I don't want people getting hurt. I don't want people going to the wrong place and not getting the right efficacy of these injections and saying it doesn't
Right.
work, because you get it done right, it works. And I've had a few that didn't work or work as well. But clearly the people you trained gave me my first one and it worked. So what do you have to say about that?
I think it's tough. It's tough to know, number one, who's a good doctor, but you'll know it when you see it. And it's, and if you have a not good experience, I encourage you to find someone else or come out to Annapolis or you know, and I'm also trying to make a network of trusted providers, but it's tough because then I'm putting my name on the line saying, hey, this person is ready to go. And I do have a few people that I have no problem making those recommendations for. I think the big thing is there are published guidelines. And I have these, if you go to the stellateinstitute.com, those published guidelines are right on there. And they can download them and complete with algorithms on when you do. We published back in 2015 when you should consider a left-sided block if this doesn't work, or and then if you have two blocks that were done really well, hey, this isn't going to work for everybody. And it, because there's other layers of pathology in there. So sometimes people might have, but the thing is, it does good at treating the post-traumatic stress injury. And I've treated people with schizophrenia or bipolar disorder
I was
and
just about to touch on that and ask about that. Thank
and
you.
PTSI. Because, and I tell them, I go, look, this isn't a treatment for schizophrenia. This isn't a treatment for bipolar. This is a treatment for the trauma you suffered, which you're still suffering from. So just because they have something else doesn't mean they don't also have this. And we can effectively deal with that layer of the layer cake of pathology. So I think that that's a big one is not, I come in like, and people are like, am I eligible to get one? And I'm like, hey, let's see what's going on. And I let them know, hey, this isn't a treatment for these other things. It's not everything, but and it's not, and some people will do a good block on the right side, will do a good block on the left side. They look like they should have been a good candidate, but it didn't work for them. Maybe what was going on in their life. That's a very uncommon situation, but it's happened. And but I think that really it's finding someone who spends time talking with you, that tries to, it's not just a procedure. I think there's these therapeutic windows that are that you can leverage to the benefit of the patient, addressing the guilt, addressing what just happened to you. And it can be very profound. I think that people that just want to sedate people and do the block and get them out the door and charge them $3,000 for the block, I think it's kind of messed up. I think it
Agreed.
feels exploitive to me.
Yes.
And I think
Like
that,
people are banking off people's trauma and just trying to get as many passed in and out, in and out, in and out. And as a patient, that doesn't feel good.
so here's the tough thing. Sometimes I see people with lower levels of medical training offering this cheaper. Doesn't mean they can't do a good block. It doesn't mean that they might not be a good person, but I don't really know, what's going on with them. I know some of them, some do and some don't. honestly, just like physicians. So really knowing who's good, it's tougher than you think. Really what they need is you're looking for someone in needle guidance excellence. So maybe someone that's already teaching ultrasound or teaching in cadaver labs, teaching this stuff. So the ultrasound guidance is the critical skill. And then you want them to have the background, like you want them to have the ACL, advanced cardiac life support equipment and current training. Because if things go wrong, and usually if they go wrong, it's because of either horrible bad luck or a lack of skill on the operator. But still, everyone's going to go through a phase where they're kind of getting things down, or some people have very different anatomy, and if you don't recognize it, bad things can happen. You have to be ready to take care of them if something bad happens. As uncommon as it is in the hands of a skilled operator, it's still, you want someone that has the right credentials to be doing this. It should be on their credentials. It should be, and hopefully you're not in their first 50, but honestly, in the military, there were plenty of people there were 50 people in my first 50, and we still were able to do it safely. But I spent a lot of time training and in cadaver labs and learning and developing the skill and understanding the anatomy. And then I had those put onto my credentials. And so you don't just get, like, in hospital credentials, they don't just put stuff on there. Somebody does the check and says, yeah, Mulvaney can do these. So I think that it's a bit of a challenge, and it's still one of the nuts I'm trying to crack, is how do we guide? I want people to get these. I don't expect to do them all. But I also am worried about people making hay while the sun shines on this and not providing high quality care that can color people's opinion of whether or not stellate ganglion block works. I know this is a quote from Dakota Mayer, a Medal of Honor recipient. I had done his first block, he did great. And then he was down in Texas, and he had someone down in Texas do his next block, and they did it fluoroscopically guided. And he said, if that had been my first block, I never would have done another one, because he didn't get any benefit at all from it. And Medal of Honor, and this is something that he talks about freely. I'm not talking out of school about a patient here. This is stuff he's put on Joe Rogan and on 60 Minutes. So it's I think honestly, for Medal of Honor recipients, it's a very hard task, because talk about hitting your thumb every day with a hammer. They earn their living as these Medal of Honor recipients. They share these valuable stories in many forums, and that's putting them right back into it. So a lot of times they probably are more subject to re-triggering than other folks, because they're making their living, a lot of times going over what happened, and it's very challenging for them. So any Medal of Honor recipients we treat for free in my clinic. So that's
awesome.
Yeah.
I did want to touch, I think I have two more things I think I may want to ask. I know you touched on people with schizophrenia or bipolar disorder, but is there any type of mental health or neurodivergent scale that you don't recommend these injections for? Like, I have soldiers that are on like the autism spectrum, and that I served with, and they're worried about what this may feel like for them, or if there's any difference for them, or if they fall into the same category as the rest of everybody with PTSD, or but I know other people with schizophrenia that also have PTSD too. So I just all these different diagnoses, is there any of them in the mental health realm that would put a wall up between you getting a shot and not being a candidate for it?
Folks with a lot of these serious, pretty heavy duty diagnoses are also in positions where they can experience trauma, either through institutional living or through the ability to not convey their stories properly. And I've treated people with autism, I've treated people with bipolar, people with schizophrenia, treated their trauma, not treated their serious mental pathology. Not that trauma is not a serious mental pathology in some cases, but it's I haven't seen it. I think there are some folks that are they're just in a really tough, irrational space sometimes. And because the one thing that can happen occasionally, it's a well-known medical fact. As a medic, you know about placebo effect. Well, there's,
Mhm.
and a placebo effect means you do a procedure and they just feel better and it didn't really do any real effect. And in medical procedures, especially, there can be a pretty high placebo effect that can last several weeks. It doesn't last months, but it can last several weeks.
Mhm.
Unfortunately, there's a dark side to placebo, and that's called nocebo. And nocebo means that you do a benign procedure and the person experiences harm, and that can happen. And the harm is real and the harm can be lasting. And it doesn't mean that anything wrong was done to them, but there's always that rare possibility, extremely rare possibility, that someone could have a procedure done, and if they're not in a rational state of mind, they can, it may not even be that, it may be just, it may be how they're wired, but it's
Mhm.
extraordinarily rare, and that can happen. And the hard part is, as a physician, how do you sniff out these extremely rare cases,
Mhm.
extraordinarily rare cases, from all the people that you can help? And I think it's a real
Mhm.
challenge, and I don't have a pat answer here.
Mhm.
One of the things, you'd sent me a list of questions, and some of them were
Yeah.
looking at, you, since Hippie and a veteran, you wanted to ask about psychedelics and stuff like that. So
Oh, yes, yes.
I just wanted to bring out that, I am, I cannot be a proponent of them. I have heard anecdotal stories from a lot of communities, including in the special operations and SEAL community, of very positive experiences with ayahuasca. This has not
Mhm.
been put into a study. This has not been, studied in a meaningful way, but they report a very cathartic experience with that. It's also very violently ill and vomiting. It's kind of
Mhm.
in a non-controlled setting, and you're guided through this after drinking this ayahuasca. You're guided through it with a shaman, a healer. And I've heard from very level, reasonable people some very positive experiences. So I'm not endorsing it, but I'm also not one of these people that just dismisses things out of hand. And so is
I'll
that
say this, just, that on just what, like, using ayahuasca or whatnot. When I first had my first shot and I came back into the emergency mental health clinic in Long Beach, the guy that, it takes everybody into this little office area, um, he was like, "So what was it like?" He's like, "'Cause it's so strange." He's like, "I can tell that you're different." And I'm like, "Oh, what happened?" I was like, "Well, how can you tell?" And he's like, "You're looking at me." He's like, "You're making eye contact with me." And now I know that if I stop making eye contact with people, that I'm starting to spiral up. But then he said, "How does it feel?" And I said, "It feels, and it feels like I did mushrooms and I have the relief from it post. That first, like, week or 2 after I did mushrooms where I feel real relief, um, that's what it felt like to me." And so, and I had just had a baby. I couldn't do anything crazy like that. I'm breastfeeding and I'm trying to keep this perfectly healthy household for my baby, for his milk. And the SGB provided that same, to me, a more long-term relief with what I had received years previous when I had done a psychedelic. I've heard a lot about ayahuasca and I'm really interested in it, but again, it's only anecdotally, and I've seen it in uh, uh, random documentaries about people using it. But yeah, it's interesting. It's interesting to see the different ways people can heal, and I definitely, my number one thing is, if I can get anybody or push them towards anything, it is SGBs. If you have PTSD and
so
you're actively suicidal.
there's a couple things out there. There's some promising initial work with MDMA,
Mhm.
and that's a part of, you have some guided, 3 guided 8-hour MDMA sessions along with another 20 hours of counseling. So it's not like you just go in and do one thing. That is showing some promise, and of course, it's very operator dependent.
Mhm.
Ketamine, I see some people get some relief from ketamine. I don't see it be long term, and I see they have to have like multiple treatments. Some people are like, it does nothing, and some people are like, no, I felt like that was a game changer. That really helped me. So I don't. There's not enough specific PTSD evidence for me to really make an aesthetic. So, and we also use it in vet medicine. It's a very safe drug, and it's a safe
Yeah.
pain reliever. So if somebody wanted to explore that, I would say that's at least safe. I don't think it's going to be harmful. Other
Yeah.
psychedelics, I think that they're going to someday have more of a role in the form of like microdosing, like you see some people doing for kind of controlling
Yeah.
symptoms. I think that there's different tools. My personal bias is to always go for the cure. Always go for to where we reset the system, and then through your own kind of whatever your pillars of a good life are. There's always going to be some form of exercise, some form of being around people that are positive. Some people it'll be some form of spirituality. It always involves your center not being on yourself, your center being on others, helping others, taking care of others. Um, and several other things, whatever your pillars are for a good life, those are the things that are going to really deeply sustain a good life. And it's not going to be, hey, I have anxiety, so I'm going to get high. Yeah, that'll make you feel a little better. But it's no different than having a few drinks. It's no different than taking a benzo. And although these things are, people like to think, and I have nothing against marijuana, just like I have nothing against alcohol or things in moderation. But when you're using it to treat a symptom, I think it's a very inelegant form of medicine. And I know people really become almost dependent. It's like a crutch. That's how they keep their symptoms down. And I have no
Yeah.
problem with somebody, I think in most states now are going this way, where it's used as a recreational drug, fine. It's used as a therapeutic if somebody, that's all they can do to get their symptoms down, fine. But ultimately what we'd like to do is get them to where it's a toxin. And all medicines are poisons. They poison the system, and we hope that what the results are better than the adverse effects that happen along with that poison. All medicines, aspirin, everything. So all of them count as toxins. If you have to use some of them to maintain symptoms, fine, or maintain a medical condition, fine. But if you don't need them, you should get rid of them. And same with, when you take, now, psychopharmacy, now you're affecting all of the transmitters in the body that use like serotonin or whichever one you happen to be attacking.
Oh, I think that was like the biggest, most important question I should have asked is medications, mental health medications. So for me, with people I counsel, medications are my number one problem, or people that are on multiple mental health
Yeah.
medications, just piled on top of each other. They haven't had any break in between any of these medications to see which one works best. Instead, they're just on a whole bunch and on sleeping pills.
In
And that just is
unstudied combinations. There's not
yes,
studies of these combinations of medicines.
correct.
Yeah.
How is the dependency on medications? How does that affect anything with the SGBs? Does it affect
No.
anything at all? So you can just get them no matter what.
What I let people, my standard advice is, hey, we do the SGB, don't change anything. And then we look at how you do it a week, we look at how you do it a month. If you're doing really good at a month, then you should talk to your behavioral health specialist that prescribed them about starting a taper. The ones I always want to taper first are the worst ones. So if they're on a benzo, I want to taper the benzos down. And you have to slowly taper benzos, because if they really are dependent on them, they can die if they just stop them. So you will end up in the emergency room in not a good way. But those are wicked, and you want to kind of, benzos are the same as taking, it's like becoming an alcoholic. They hit the same GABA receptors as alcohol, except for now you're taking like heroic doses of alcohol, except for people don't call you an alcoholic. You're just someone with anxiety that's taking a benzo. You're just taking your Xanax just to get your Klonopin, just getting through the day with your Klonopin, and you really, it's just a very inelegant way of dealing with the symptom. So a lot of these things are just dealing with symptoms. I'm all about it. Sometimes you have to get through the day, but the best solution is when we can get you living your life, being around your friends and family without being a beast, and seeing the beauty in life all around you and realizing this is good. I want to stay here. I don't want to die.
Oh, well, thank you. And thank you for answering all of the questions and all your information and all the work that you have done and continue to do in changing what it the way we approach PTSI, excuse me. You made a huge impact and difference in my life, and so many of my own friends and people I love and hold dear, not just as secondary people in my life, but other veterans. And I just hope and pray that whatever you're doing just keeps expanding. I don't know, I want the VA to just listen to you. I want you in charge of the VA.
And I want
please.
I want them to do it right. And that, I think that's the important thing. And I appreciate your thanks, but I really want you to know, like what I get to do every day, the path I'm on now, and seeing people and helping people every day is amazing. You know,
It's
so
amazing.
I feel like this is my, both what I did in my past and what I do now. It's just part of this path, and I'd like to see it through. And it's I feel so lucky to be on this, because it's helping a lot of people. I'm actually sincerely very humbled by all of it. I realize that my part is a tiny part, but I still feel compelled to try to get this out there, to try to amplify this message, to try to reach these people before they make a horrible decision.
Definitely. As I said, all veterans, I mean, most veterans have dealt with losing friends or having suicidal ideations, and it's such a problem. But the loss of people from suicide it just keeps piling up, and that's what motivates me to just be so loud and talk about it. I lost people I love just to suicide. I'm really done watching my brothers and sisters suffer. When there's something and there's someone that has the answer.
Yeah, I mean, there's no veteran, including myself, that hasn't really touched. I mean,
yep,
it's quite horrible, but it's but I really feel like this is moving forward. If something better comes along, I'll be an advocate for that. I really thought when I started doing this, when I first started, you know, even from case one and published my first paper, I'm a musculoskeletal physician. I thought that I'd just be patting a snowball at the top of a huge snow-packed mountain slope, and I dropped the snowball and it would just turn into an avalanche. I'm like, this is working. This is amazing. And then the snowball dropped in the snow 2 feet in front of me, didn't move. I published another study, this one of the 166 guys with 4-month follow-up. Again, it went nowhere. And in fact, I was told by experts at Walter Reed that this is just really nothing. This means nothing right now. And I was like, what? That was my first real introduction to academic medicine. And then we did a multi-center randomized control trial that took 4 years to do. And then they're like, and publish it in JAMA, which is really hard to do. It's a very high quality level of evidence. And that finally started getting some traction. It was that article, that publication. And Christine Ray Olmsted was the lead author on that. I wasn't the lead author. I was third author on that one. But she, that when that paper got published, that's what got the attention of 60 Minutes, and that's what kind of started this. And then we were really getting some traction. I know, and then COVID happened, and a lot of the traction just kind of, people stopped being able to travel and dropped off. What I see now is that what my role is, I want to be an honest broker on this. I want to I have to figure out a way. I'm still in clinical medicine. I mean, every day I'm in clinic, every day I'm busy and treating people. And so I'm happy to be able to help one person at a time as part of my practice and as part of Dr. Lynch's practice. But oh man, we want to move this forward ethically, responsibly, safely, in a way that can help a lot of people. But in the meantime, I keep thinking this should just have taken off completely, and it keeps not taking off. And it used to really feel like a big burden to me. And I'm just trying to realize, hey, medicine moves slow. There's reasons for this, and we'll get there.
I seriously, I mean, clearly I don't feel the same way, since you're the person, this is like literally your life's work. But after I got it and I experienced the relief, and then that article, there was another, I think it's the one you're talking about that which one got published in like 2019, like in November or somewhere around that time?
We've had a couple publications. One of them was on the 2-level block. One of them was on a left-sided block.
Like, I thought that it was going to explode. I thought that this was like, military.com had made this article about it. I was like, oh, look, you guys, you can get relief. Like, you're not crazy in your heads. Like, come on, hello. And it didn't go anywhere. And then COVID did hit. And I don't know, I've been heartbroken about like screaming about it. Cause this is
Yeah,
real. This is
but Lauren,
legitimate.
so here it is. Like I do this research, I do this stuff, but honestly, it's people like you that are really going to help people. It's people like you that are getting this word out. And when you help one person, that's a life that you might have saved. Heather Abbott was a producer for the 60 Minutes segment that was on, and I call her up, at least once a year, and I say, look, these are all the people that you've saved. And she said, yeah, they do lots of stories on 60 Minutes, but she shared with me, she goes, we don't get letters about stories. She goes, we get letters about that segment, about the lives that we saved. So
it changed my life. You changed my life.
But it's people like you that are getting this out there, that are amplifying this message in a sincere fashion, and hey, I'm just trying to help fashion. That's people, that resonates with people, and this is what's going to do it. Thank you.
That's awesome. Thank you. Right back at you. But yeah, so thank you for coming on. I'm gonna go ahead and hit